Hello, I'm John Kelly, and I'm one of the tutors at Macquarie University, and this talk is about the knee examination. There's a number of scenarios where a knee examination is going to be relevant. I like to break it down into these 7, as I find that in each of these different scenarios there's a slightly different differential diagnosis and therefore a slightly different history and exam for each one. So I break it down into medial knee pain scenario, lateral knee pain scenario, anterior knee pain scenario, posterior knee pain scenario, the global knee pain without swelling or warmth, which is generally an arthralgia, and then there's the global knee pain that's with swelling and warmth, which is an arthritis, and then you have a trauma scenario, whether it be a sports injury or part of a major MVA, motor vehicle accident. So, as I said, that I break it down into those. At your stage as a medical student, you're not expected to have a wonderful list, particularly for the top 4 there. But as you get more experienced, you certainly should try and get a list for each of these. Regardless of which scenario, a good way of thinking diagnostically about the knee is to consider it from an anatomical point of view. So say someone presents with a knee pain, I can think of is it from the skin or subcutaneous tissues, for example, like a cellulitis or an abscess related to the skin. There's various burses that can be inflamed. There's a thing called fat pad impingement, which is another structure that can get inflamed and cause pain. There's a number of tendons and a number of muscles. There's the joints, and you might notice there's the patellofemoral joint and the tibiofemoral joint are the main 2. There's meniscus problems, there's ligament problems, and you might notice specifically there's amongst under ligaments there's the cruciate ligaments, so anterior and posterior cruciate ligaments, and then there's the collateral ligaments, which is the medial and lateral collateral ligaments, and then there's the other source of pain of presentation, which could be bone, potentially nerves, and there's that question of whether the problem isn't actually from the knee at all, and it's actually referred pain from either the hip or lumbar spine. So this is how I think of the approach to diagnostically, and this has a big impact on exactly how I physically examine someone's knee. The red flags are going to vary with each of those 7 presenting scenarios that we talked about. However, it's worth going through some of the sort of the important red flags overall, as these affect what you ask in your history as well as your exam. Particularly in this scenario where there's a swollen, hot knee joint, particularly and you've decided particularly that it's not a prepatellar bursitis, so you think it's actually an arthritis. The most important thing to consider there is septic arthritis. You can destroy a knee over hours to days, and so therefore it's an important diagnosis to consider. So that are particularly relevant in the person presenting with that swollen hot knee, and this in turn can be due to normal organisms like Staph aureus, but it can also be due to STD, sexually transmitted disease-related organisms. The other infection that I consider in areas of high risk of rheumatic heart disease, so remote indigenous communities, developing countries, is rheumatic fever, and these can also present with arthritises and also arthralgias, and only in those high risk groups, this is an important diagnosis also not to miss. It's a red flag in that population, and they present differently. So if you're working in those areas, you really will need to know those red flags. But certainly don't forget the septic arthritis. Then you've got the dislocated knee. This would be something you'll consider in the trauma scenario, and it's basically where you find there's more than one ligament gone. So if you diagnose one ligament injury, that's not a dislocated knee, but if you find there's more than one, you have to think about this, because these are knees that completely dislocate, then they come back into place, they look okay, but actually they may have done significant damage to their arterial and peripheral nerve supplies, and if you don't think about it, you won't diagnose it. So always think about it when there's more than one ligament injured in a knee. There's a thing called a posterolateral corner injury, which is the posterolateral corner of the knee. Again, only relevant in the trauma scenario, although I guess if you had a trauma and then you've missed the diagnosis and they've come in more chronically with posterior or lateral pains, you have to think about it. Again, it's where there's often more than one ligament gone, and some other structures. And again, these people, it's important to treat these because they often need orthopedic interventions, and they can also get nerve damage. Fractures are naturally quite important not to miss. So there's a number of so you do consider someone's got osteoporosis, and you do consider the mechanism of the injury, and we do on physical exam look for some tenderness in some of these locations. Someone who can't, and we have a set of rules clinically on who needs an X-ray to rule out a fracture, which as you do your training you'll get to learn about. Then there's what's called a bucket handle meniscus tear. These are people who have these twisting injuries, and in this particular type of meniscus injury they can't straighten their leg, it just locks. It locks in a certain position, so they can't fully extend the knee. And when you get these people who they've often got a lot of pain and can't move their knee too much, but if you really can't get them to straighten it out, they also need a fairly prompt orthopedic referral. People who've got what's called a problem in their extensor mechanism, which is, so you have this quadriceps going onto patella tendon that extends the leg, and if there's been a rupture of that quadriceps or patella tendon, they also need fairly prompt orthopedic input. Another key thing not to miss is hip pathology that presents with knee pain, and as an example, kids under the age of 16 are a bit prone to a thing called slipped femoral epiphysis. It's basically a type of growth plate fracture in the femoral epiphysis, and if you miss these, they can go and get a vascular necrosis and do really crumbly on. And so you always examine the hip when someone comes in with knee pain, unless it's very obvious what's going on with the knee. And the other one, just to be careful, is under 16-year-olds with swelling of the knee. There's a number of causes of this, so but none of them particularly they're all as a general conditions that you don't want to miss. So these are my red flags for the knee. And the reason I mention this early in your training is because it's going to affect your history and your examination up front, and it's often good to know the why we do things. I'm just going to give you an example of one of those scenarios, and over the time I guess you'll learn the other scenarios about what's relevant in their history. But if we just look at the history of a trauma scenario, just want to just point out that these are the key things just to focus on. So the exact mechanism, even getting the patient to demonstrate it, is really important. So people who say get a force coming from outside of their knee, pushing their knee medially, so that might cause a strain on their medial collateral ligament and if it goes the other way, it might be the lateral collateral ligament. A hyperextension injury makes you think of other structures such as posterior cruciate being injured, the twisting on a grounded leg, twisting of the knee on a grounded leg makes you think of meniscus injuries. Awkward falls or awkward landings, particularly when doing cutting or sideways movements in sports or at work, makes you, and particularly if you get a history of a popping at the time, so some kind of tearing at the time, which either sometimes even someone else can hear or the patient more commonly notices, makes you think of an ACL, an anterior cruciate ligament injury. And in fact, the history, some orthopedic people say, is enough for them to make the diagnosis, which is a bit tongue-in-cheek, but actually quite true. Another key question is to know is whether someone was able to play, say they're on the sporting field, able to continue playing, or did they have to get carried off? For example, an ACL, an anterior cruciate ligament injury, they will not be able to continue playing. They'll be taken straight off the field. So that's diagnostically an important question to ask, therefore. With someone with, say, a medial meniscus injury, medial collateral ligament or even meniscus injury might actually be able to continue on with their sport. Knowing the location of the pain is relevant because different locations make you think of different structures. And whether the pain is localized or diffuse. Remember, localized means being able to pinpoint with one finger. And for example, localized will be typical of a collateral ligament injury, whereas a cruciate ligament injury or, say, tibial fracture will be more diffuse. So that's very useful. Whether they're able to walk at the time of injury and subsequently, again, very relevant for the similar reason as to why ability to continue playing was relevant. A knee effusion the presence of a knee effusion is important, but the timing of it is particularly important. If it occurs less than 2 hours after an injury, then you already know with a high degree of certainty this person has either had an ACL injury, an ACL tear, or a patella dislocation, or a intraarticular fracture, or sometimes a peripheral meniscal tear. And so you've instantly narrowed your diagnosis down to 4 things just by virtue of that history of timing. Subsequent effusions can be due to things like meniscal pathologies of other sorts and chondral injuries, but so that timing is really critical. And these ones that do blow up into less than 2 hours, it's because of a hemarthrosis. Locking of knees is quite relevant because it can imply fragments of bone or of cartilage that are floating around, or meniscal tears where it's actually where, particularly bucket handle meniscus tears, where a bit of meniscus is actually getting jammed. But you have to ask this key question about locking, which is what position does the locking occur in? If my leg is in full extension and I find sometimes it's locked in that position, that's not what I call true locking. True locking is when you physically can't extend your leg past a certain point of flexion, and it's often a similar spot, and sometimes you can jiggle it, and eventually with a clunking or clicking that's often painful, suddenly be able to release it back into full extension. That's what you're interested in, because that's the one that tells you, yes, this could be a bit of meniscus getting caught or a foreign body. And it also tells you this person's more likely to need the orthopedic surgeon rather than any conservative treatment of their meniscus pathology. So it's a very important symptom. Giving away of the knee is really important, but when you get that history, you have to bear in mind there are 2 sort of main reasons for that. One is that people who just have pain in their knee for whatever source. So there's a number of conditions that do that. These people will feel pain, then their knee feels wobbly, and it's particularly when they're doing straight line activities, so walking or running in a straight line, and it's particularly because as they're flexing their knee, it buckles and gives way. That's just a response that our quadriceps does in response to pain, where it decides not to work and it gives way and feels wobbly. That is there's a different type of giving way that ACL, so anterior cruciate ligament injuries have, where they have giving away whenever they're trying to do activities like side bending or cutting. So it's sort of non-straight, not straight in a line sort of activities, and so it's really good to bring that out in your history, not just say, oh yes, there's giving way of the knee. And then you naturally just want to know, well, what were the initial management of the knee, and when did of the injury, and when did it happen? So there's just a few key questions in the history to ask. In social history, it would be very relevant to know whether the injury occurred at work, because then they could apply for workers' cover as opposed to use up all their sick leave. So that's very important in any musculoskeletal injury, and knowing the occupation and how that relates to their injury and whether they're able to still work. All those things are really important. And then the other thing which is really relevant in all musculoskeletal injuries is the sporting and training history. So, what sort of sport, specifically what do they do in that sport, and their training, whether they've stepped up their training recently, maybe that's a trigger for why they've got their injury. And what level of sport. Someone who's pretty high level, you're going to be more likely to refer them quite promptly. I'm not going to, if I had some elite Olympic sportsman, well, I'm actually probably not going to be the one that just looks after them. And the other thing is just the impact of the injury on the sport and what's happened. So all that can be, imagine, be quite relevant. And then past history, which includes previous injuries to knees and other musculoskeletal structures, and also what tests and surgery they've had. So that's just an example of history as it relates. So the sort of the key features, I should say. You're naturally still going to take a proper pain history, and as you would have learned at the very start of medical school, about how to take a pain history, but I'm just pulling out the things that are important here. So let's now go to the physical exam overview. So in general, these are the essential structures of a physical exam. It's exactly the same as a hip. If you think of just the essential structures, it's stance, or any lower limb thing really. It's your stance, some kind of simple functional test, which would invariably involve walking. And in the case of the knee, we'll often like to do the deep squatting. You might remember with the hip it was walking and straight leg raise. But you might also just want to pick out some kind of functional activity that brings on their particular pain. There's inspection, so and I think an inspection systematically is skin, subcutaneous tissue, the muscle, the bone, which is the alignment, and the joints. That's my way of thinking of that. And then there's palpation, so we'll have a system for that of the knee and the surrounding structures. And then there's the movements, and it's the same thing as with any musculoskeletal thing. There's passive movements and active movements, so that's the range of movement. And then you're going to specifically test the muscle activity itself of the muscles that are involved with that joint. Then there's going to be a variety of special tests, and in the case of the knee, it's really targeting those collateral ligaments and those cruciate ligaments and meniscal pathology. But there are some other fancy tests. So there's one, for example, to see if the patella subluxes, which might have been relevant if, say, you're suspicious of a patella subluxing, such as an immediate hemarthrosis, as in that trauma history. And then you're going to do an examination of additional areas of the body. So in bold, you can see here, I've got essentially the structure of any musculoskeletal exam. I'm just putting it specifically here to the knee. So for the knee, additional areas of the body to consider exam will often involve the hip, because knee pain can be from the hip. Neurodynamic testing, which is at your level probably going to be the straight leg raise. There is one called the slump test. There's doing some kind of neurovascular assessment of the limb, of the structure distally, so in this case of the knee, so the knee distally, and an examination of the lumbar spine, because the lumbar spine can refer itself to the knee, and then some general exam as guided by the history exam. So if I thought the patient had gout, I might look for evidence of gout elsewhere, or if I had rheumatoid, look for other evidence of other joint involvement and other features of rheumatoid. So that's that. We then go to the preparation and general inspection. Yeah, as with any musculoskeletal examination, you start with, or any examination really, you start with an introduction to the patient, explain proposed examination, get the verbal consent, make sure there's privacy for the patient, wash your hands in front of them, position patient appropriate for the exam. In this case, that would be a standing position, and the usual attire that's ideal for this case is the shorts and bare feet. And then you'd go on to your general inspection, and vital signs is considered appropriate. And so I guess in this situation it'd be things like presence of a walker or stick, how they're mobilising around in the consultation, well or unwell, overall muscle bulk. We now go to the stance and simple function tests. And as with most lower limb things, I often look just globally at them. So are their shoulders aligned in the same horizontally? You look in their back to see if there's any scoliosis. So if you can imagine looking at their back, just making sure it runs down the line. Make sure the ASASs are roughly horizontal with the ground. Yep. And then make sure that the hip, knee and ankle align like so. And then I'll look at the knees to see if they're inturned in one direction or the other, and that they're not flat-footed or have any obvious ankle problems. So it's sort of more of a global sort of assessment. And I might then hone in a bit more specifically as regards the knee. So I think in terms of skin, subcutaneous tissue, muscle, joints and bone. So skin, is there any obvious scars, bruising, redness? So I think here there's some varices. Muscle, I particularly look here in the vastus medialis, which is this part here. I can look at the calf muscles, so looking just for general wasting in anywhere or asymmetry. Joint, do the knees joints look swollen or not? Often a bit hard to tell for gross, except for gross effusions, but you'll often see these dimples if there's no obvious effusion. And then I go to the bone, which is the alignment, and I look here to see if this is lined in going right down from the hip down, looking as regards the knee, particularly for varus, which is bow-legged, or knock knee, which is valgus, so where you get an angle like that. And that would be the main things I check for here. The only other comment I'd say is that you look for any obvious swelling. I guess you could call it, like if you had a big tumour, you might find one area is much more swollen than the other. I do look side on. So there's a thing called genu recurvatum. You can look that up. There are abnormalities of alignment that you can pick from that angle. You might be able to pick if they are flat-footed they are. and then look from behind. As regards, it's so through to the same thing, the skin. So here the varices are much more obvious. The muscle, is there any, what do the hamstring muscles look like, and the calf muscles in terms of wasting or hypertrophy. And a particular thing you look in the back here is for any Baker cysts, which will often be where the medial group of the hamstrings come in here, and it's sort of in between them you'll find an out-pocketing, which might be a Baker cyst, which is relevant in people presenting with posterior knee pain. And again, so that you can look at your alignment. Then I go into functional testing, so in order to get this patient to go for a walk. So the main thing you might find is an antalgic gait, so short stance phase due to pain, but keep an open mind. Because neurological exam is important, distally of any joint, standing on their, walking on their toes is a good test of plantar flexion. And walking on your heels, actually easy with your shoes on, is a good test for dorsiflexion. As I said, you may want to do some more other functional tests. So a squat is quite a good one to sometimes reproduce patients' pain. If people do get pain, ask, is that the pain you are complaining of to me about? So you can tie it in with their presenting symptom, and you might just put them into any position that they know that they get the pain. The squat is quite good because it puts a lot of load on the knee, and it's very relevant for quite a few pathologies. Patellofemoral pain, meniscal pathology, just to name two. I then go to inspection on the bed in the supine position. So we really just go through that same system of inspection as we just did with before, so I won't repeat that. We now go to palpation in the supine position. Key thing about palpation is you ask them to locate with their finger where it's the place that's sore, and if they can't locate it, it's called poorly localized. If they can locate it with their finger, it's well localized, and that, as is mentioned, can be quite diagnostically helpful. The other thing is if you do elicit tenderness, ask, does that recreate the pain that you're complaining of? Because a lot of places are tender, but what you want to know is that tenderness related to the structure that that might be causing the pain that they're presenting with, and you might even get them to grade it out of 10. So the palpation starts off with feeling for the skin, so feeling for any warmth, dark skin that's maybe the way you can pick a cellulitis, and allodynia. I'm now going to go to the near fusion. So you can see here I'm milking the bottom part of the knee. This is for a subtle effusion, so getting any fluid from any burses and all that to be pushed up into the knee joint, the intra-articular component of the knee joint itself. And then I'm pushing down the other way. And now I'm going to proceed to what is called the wipe test. And the wipe test is going to involve me wiping one side and the other, and what you're hoping is that when you do the second wipe, that fluid will pop out in a little bulge here where there's normally a bit of a depression. So I want you to look at that place and tell me if you think this person's got a positive wipe or not. Okay, and now this is for moderate. This is patella tap, where you're tapping the patella over the bone. That's for moderate effusions. So this person, I'd say, did have a positive wipe test. So you can repeat that, go back to have a look at that if you're not sure. For really obvious effusions, and this is not an obvious effusion, this is actually my knee, but you can imagine if this dimple here was actually bulged out that side. It's usually quite obvious they've got a knee effusion, but what you can do is you can push on one side and see the fluid come out the other. And what actually you can do, it's even better than that, is you push on this side and then have your thumb on the other side to feel it actually cross-fluctuating, the fluid cross-fluctuating across. It's called a cross-fluctuation test. So that's just a test you can use for gross effusions where it's actually pretty obvious they've got a knee effusion, but not always. So let's have a look at that in action. In this case, I don't think he's actually going to put his thumb on the other side, but that's what I would do ordinarily. And look at the other side and see if any fluids coming out in that area. So it's not actually coming out in that depression area, is it? It's so there's no and you can imagine putting your thumb over that depression on the other side for cross fluctuation. Okay, so we're now going to do the rest of the palpation. I now do the anterior structures of the knee. So I start with the quadriceps. Quadriceps can be affected by contusions or tears, or as they're a little bit more distally, as it becomes more tendinopathies. And so you're feeling for sites of tenderness or any defects, as in the case of a complete tear. And so we'll see that in action. So I would have asked, tell me if it's sore and tell me, does it recreate your usual pain? Okay, I'm up to the patella. So the patella, I just work my way down superiorly to inferiorly over the body of the patella, really just looking to see if there's any obvious tenderness, say from a fracture, or so we'll continue on. I now go to each side, so I'll start with the medial side of the patella. There's like a retinaculum and some ligaments on that side, and also there's you might find there's certain structures that can be painful, things like quadriplecas and or facet joints of the patella that can be tender. So you're trying to feel basically for any tenderness and bumps underneath each side of the patella. And to do that, you're going to shift the patella a little bit off to the sides. You're going to move it laterally. Part of the problem that with moving it laterally is some people who are prone to a thing called patella subluxation will get apprehensive when you do that movement laterally. So if they suddenly go, stop that, then you need to stop that and think about that condition. And so let's just see that in action. And then I'll go to the other side and do exactly the same thing. Okay, I'm now up to the inferior pole of the patella. That's where the patella tendon actually is, and there's a thing called jumper's knee that can give you localized pain there. So if it's tender, then you obviously got to ask them, does that recreate your usual pain? And if the history was a well localized pain there, well, that supports that. But just beware, it's a common site to be tender, so if it doesn't recreate their pain they've come in with, don't put it down to that. So we do that. And so you can just see that's where the patella tendon is. Basically got your hand on the patella tendon there, or fingers. And then you're going down to the tibial tuberosity, which is will be tender in a condition called Osgood Schlatters, which kids get. So basically gone from the inferior pole of the patella onto the tendon and now onto the tibial tuberosity. And our palpation at a medical student level is probably going to stop there for the anterior knee. As you get more advanced, there are some other structures to consider feeling. So on either side of the patellar tendon, so here's the patella, tibial tuberosity, and there's the patellar tendon in between. On either side of this, if you push down on those, is what's called the fat pad. So if someone's got fat pad impingement, they'll be tender in those two spots. There's a spot, a little bursa under these hamstring muscles as they run their way up here. There's a little bursa down here. They can get inflamed, so that some people will have this tenderness down here for a thing called pes anserius. And then there's another site that relates to iliotibial band problems over here. They're things you don't need to know as a medical student, but I'm just putting them there in case you're a physio and thinking, well, why aren't we doing all those? So just so you just got the complete picture. So I'm not asking you to do those things, but I just thought I'd mention them here while you're here. So let's continue on. I think, in fact, that's the end of this that exam there. So we're now up to we now go to the sides of either side of the knee. What we're really focusing on here is the joint line and the collateral ligament. So the lateral side will be the lateral collateral ligament and the medial side will be the medial collateral ligament. So with that in mind, we'll watch what he's doing. I will point out a few things actually before we do that with a pointer. The joint line is a lot further down than you think it's here, and to bring it out you really need to bend the knee to at least 45 degrees and even up to 90 degrees, and it's what the patient will allow you to do. The more you bend it, usually the more obvious that gap becomes between the femur and the tibia. What you're looking for, joint line tenderness will often go with meniscal pathology. So this time, this lateral side will be the lateral meniscus, but it can go with things like arthritides, like osteoarthritis. You've also got running this way the collateral ligament, and so you'll actually, in fact, you can sometimes feel the lateral one because it's like a cord, and so the relevance is it'll be tender from here down like that if it's a collateral ligament, and when we go off and do special collateral ligament testing, that'll support that. Whereas a joint line will be tender this direction. So your palpation can try and help you distinguish which is which. So anyway, with those comments in mind, let's watch what he does. So he's asked the patient, is it tender, and does it create your usual pain? So you can see he's running along there. Because there's no tenderness, he hasn't bothered to explore the, to go up the other direction for the collateral ligament. But just bear in mind, if let's say she'd said, oh yes, it's sore here, well then you would have been putting your hand, if it's there but it's not sore here or here, then you would be going up this way and seeing if the tenderness is in that direction to support a collateral ligament. Just as a tip, if you are you can actually feel these ligaments, these collateral ligaments, and the tip for the lateral collateral ligament is you can actually angle your leg in such a way that it brings out that actual ligament. And in fact, on my leg, I can actually see it and feel it. So let's just see that in action. So I'm pulling it out in that way. So basically putting my leg across, you can see I'm putting my foot onto the other leg, And now that it would be much more obvious. I'll be able to feel this band-like thing. I'm feeling it now. I can feel that band-like structure, or that cord-like structure of the lateral collateral ligament. Okay, we now go to the range of movements, which is defined as active and then passive, as for most musculoskeletal problems. So let's go and see them in action. So we're going to start off with active movements of the knee, and then we're going to go into passive. So we start with flexion and see if she can actively fully flex her knee. And if she can, well, you can presume that passive is going to be just as good. If it isn't, if she's not able to fully flex it, then you would passively move it in for her until it's too painful for her, watching her eyes carefully. So that's passive flexion of the knee joint. And then you're going to get it to do actively extend. So she's doing it herself. And now, if I don't think she's actively extended it fully, which often you can't tell because a lot of people will hyperextend their leg, I then will passively do the remainder for her, which is what I'm doing there. So if you rewind the video there, you'll notice actively she doesn't quite get out to where I got to there. Maybe that's because she wasn't giving enough effort. Maybe it's because she had a general weakness.
The same with this side.
And then just going to go to the other side, of course, do the same thing.
That's it. Straighten it out for me. That's good. Straighten it right out. That's good. Just have a look like that.
Now what I'm going to do is look for any just subtle fixed flexion contractures of, like say from tight hamstrings, that might be rendering that knee in a position of fixed flexion at all. I have not that I've detected that. This is just part of the second part of my passive movement. So just watch this in action. You need to see this side on. So you see I'm holding both legs. The camera will now, you can imagine I'm looking at the angle side on there. And what I'm looking for here is if there was if you just say this leg here was in a fixed flexion, it'll be higher than that one. So this one leg would go up like that, and like it'll be that sort of shape, whereas this one would remain the same. So that just picks out the subtle fixed flexion contractures. So it's just a second thing. Look, from a medical student point of view, probably just get that first part right of active and passive movements of flexion extension, but this bit, I guess, is what I just call finesse. The third part of the passive movements is I'll check for crepitus, which is by putting my hand over the kneecap and feeling for it. So you can see that happening here.
That's that. I'm just going to yep. This side. That's that. Okay. That's that.
Okay, we're now into the third component of movements, which is the resisted muscle testing. A particular reason I do this is that if there was a problem with a particular muscle or tendon, doing resisted testing of that muscle will often recreate the pain. And if that, for example, so if I get a history of say pain behind the knee laterally, and I examine and find that area is tender, and thinking over the biceps femoris, then I know that if I do resisted testing of flexing that knee and I recreate the pain, then I'm really strongly starting to support my diagnosis that this person's got a tendinopathy of their biceps femoris. So that's how it works. And I guess there are other values of doing resistor testing, but that's the one I want to highlight here. So let's just watch this in action. Basically, you test any muscle that crosses that joint. So we're going to start with the quadriceps. Some people wouldn't put that hand underneath the thigh; they'll just raise the whole leg. But so that's
okay. I'm now going to get you to bend your leg in for me. Push it in strong.
So this is now testing flexion of the knee.
This side, strong.
So that's my hamstrings being tested basically, such as the biceps femoris. And then the other muscle that crosses the joint.
Down for me. Down.
So here I'm having a bit of fun and games trying to explain it, which is often the case when you're explaining to patients. So you notice I've got to bend the knee and then push the foot down. You can't do this with a straight leg. So that was the calf muscles basically. So what I've done there is tested the quadriceps firstly, then I've gone to the hamstrings, which is your biceps femoris laterally and your semitendinosus and membranosus medially, so that's your hamstring groups of muscle. And then I've gone and tested my calf muscle, bearing in mind you can't test the calf muscles, which is your gastrocnemius and soleus, really effectively without bending that knee to get proper strength.
Good.
We now move to special testing. Special testing when it comes to the knee, the main six are the testing of the medial and lateral collateral ligaments, the anterior and posterior cruciate ligaments, and the medial and lateral menisci. I think they're the ones I'd learn to master. There are other tests, such as the patellar apprehension test for subluxation and a host of others, but I'd focus on these top six. And just what we're going to show at the moment is the how to do a medial collateral ligament assessment. So this is someone's right leg. Unfortunately, my video didn't work, so I've got this one off the internet because I needed to get this PowerPoint out. And what you can see here with this person on there is that the medial collateral ligament would be here. And what you're trying to do is this hand here is going to push the thigh in that direction whilst this hand stabilizes, which is hopefully going to try and make that joint line open up. Now, if that collateral ligament's doing its job, it's going to resist that and not cause pain. If it's partly torn, it'll cause pain. If it's a grade 2 or 3 tear, it'll actually cause that gap to open up when he does that. So let's have a look. So let's see him do that and see what happens. Here he goes in the starting position, and often you might notice he's actually put his finger over the joint line there so he can actually feel it. And now let's see what happens when he applies that force with this hand here. He's done that, and the gap that he's feeling with his finger hasn't opened up, and it hasn't got any pain, so it's a negative test. And then you can switch these hands and put this hand over, you make this hand be the one that applies the force on this side, and that hand support the calf and do the other collateral ligament. So it's just the opposite, just hand positions for testing the lateral collateral ligament. So hopefully that explains that test. So we're now up to the test for the cruciate ligaments. I'm starting with the anterior cruciate ligament, and the concept here is that the purpose of the anterior cruciate ligament, to put it simply, is to stop anterior translation of the tibia relative to the femur. In other words, stopping the tibia from moving forward or anteriorly relative to the femur. And the way it does it is, as you do that translation, the ligament, like this piece of rope, suddenly becomes taut and prevents further translation. And just like a rope, so the idea of this first test, which is going to be the Lockman's test, is you're going to physically try to push pull the tibia forward relative to the femur, and just like a piece of string, you're going to hope that you feel that piece of rope become taut, and then you're going to measure just how much translation you got and compare both sides. What's important about this, as I hope this video will show you, is that the endpoint you're looking for with these tests is both the degree of translation, but also that feeling of the rope becoming taut. If you find that you don't get that feeling of a rope becoming taut suddenly, then that means that cruciate ligament may not be working. And that means that when you do your technique of this test, you've got to pretty much jerk the anterior cruciate. You've got to jerk the tibia forward compared to the fibula, to the femur. So I'll just show you this on this video. That is the action of these tests that you're going to be doing, as opposed to that, where you're not doing that jerking action. In that former one, you feel the endpoint, you feel the rope become taut, whereas when you just slowly do it, you don't. So let's look at the tests in action, starting with the Lockmans. So with the Lockmans, the first thing is you put your one hand underneath the thigh to support it, and the idea of the Lockmans is you go to 30 degrees of angle. So let's have a look at that. There you are. So that's where that hand goes. Now the other hand is going to go to the tibia and curl around the tibial tuberosity, so that the thumb lands on the tibial tuberosity. And you've got to relax the patient. If they're not relaxed, they're going to have other structures that will make it feel like it's the ligament is working when it's not, so it's going to reduce the sensitivity. So you can see that other hand is going over the tibial tuberosity, which is part of the tibia. And I'm going to do that jerk just like that rope.
Leg a sudden jerk.
Yep, so making sure it's just all relaxed. Very important, that part. Just hard in the acute setting. See the jerking, just like pulling the rope? And what you're looking for there was any translation. My hand's over the tibia, the joint line. So the joint line will be here. Okay. And I'm pulling this hand up that way and seeing if there's any give here. And I'm also feeling for that rope becoming taut. They're the two things I'm doing. And I could then compare it with the other side. And so you can look into your textbooks, but basically if that goes beyond so many millimeters, it's abnormal, or if it's so many millimeters relative to the other side, it's abnormal, or if I lose that end point of the rope becoming taut, that's also abnormal. Let's get rid of the... Right.
What's that one?
Okay. Now, what we've shown so far is the Lockman's test, and now there's a problem with it, which is essentially that there is one cause of false positive, and that is that sometimes the problem is that the posterior cruciate ligament is the problem, and its job is to prevent forward translation of the femur onto the tibia. Or to put it another way, if the leg is in this position, or in the position of that Lockman's at 30 degrees, this tibia is naturally going to, by gravity, if that posterior cruciate's not working, this alignment here will actually go, that ligament won't allow it to stay in that position, and it'll actually sag, with the whole tibia will move from here to here. So it moves that back that way. And The relevance of that is if you went off and did a Lockman's test on that, or an anterior jaw, as we're about to see, you are going to get excessive translation of the tibia forward in this direction, but not because the anterior cruciate ligament's the problem, but because the posterior cruciate ligament's the problem. So it's starting from further back. So to get around that problem, we do what's called the posterior sag. And what that is that there's this interesting thing where here's the femur, and now we're crossing the line into the tibia, and on the tibia there's this tibial tuberosity, and you'll notice that it's actually, if you draw a line, if you imagine this is an imaginary line here of the bone, you'll notice that this tibial tuberosity is a little bit further forward compared to the femur. And so what you're doing is you're just making sure that you've got that bump here, that it's like that, as opposed to that, say. So as long as that bump is further ahead than here, if you can imagine that your advancement is this way, if you imagine that, if here's a line, as long as that bump is ahead of the line, there is no posterior sag. In other words, that posterior cruciate is probably intact, and so if you did get a positive Lockman's or an anterior jaw, you can say, yes, that's a real weakness of the anterior cruciate ligament. So what we call this is whereas if that bump was back here, so let's say that this line was more like that, then you would say there's a positive posterior sag, and in which case the reason for the positive anterior jaw might be because of a problem actually with the posterior cruciate ligament. So we're now going to proceed to, having done that, to what's called the anterior and then the posterior jaw test. The anterior jaw test is exactly the same concept as the Lockman's, except instead of being at 30 degrees, it's at 90 degrees. It's not quite as sensitive as the other test, but we often do both. So let's see that test in action. And you'll just see it looks exactly like the Lockman's, and it's the same thing. You're looking for excessive movement or that lack of that tautness, and you are going to compare both sides. Actually, what we're going to do first is do the posterior sag test. So let's see what they do. We're going to demonstrate the posterior sag test first. So we're putting both. We compare both sides together. Make sure that bump is ahead. Okay, and now we're going to go into the anterior jaw test. And the way you do it here is often you'll put a foot, you'll put your bottom on the person's foot just to stabilize the leg, and you're now putting your thumbs on the tibial side of the joint line there. So they're on the tibia, but right up to where the joint line is. Okay. And you notice it's 90 degrees. So this is the anterior jaw is done at 90 degrees. It's just like a Lockman's, except it's at 90 degrees, not quite as sensitive.
Let's go and do that jerk again.
Here we go. So just putting my bottom, there it is.
Okay.
And now I'm going to go the other direction and do the posterior jaw, which is specifically testing the posterior cruciate ligament, which is exactly the same thing, except I'm now jerking it the other way. Just
the other direction now.
There it is.
Okay.
And I'm just going to do the other side. So what we've seen is same thing. So my thumbs are just on the tibial side of the joint line, anterior jaw, and then posterior jaw.
Okay. What's that?
So we're now going to move to some tests, the test for the meniscal pathology. If you think of it, there's sort of like the cushionings or the shock absorbers of your knee joint. There's a lateral one and a medial one, with the medial most commonly being affected. You'll get a suspicion on it because people will have pain, particularly on things like squatting or going upstairs. It'll be over the medial joint, so in the case of the medial meniscus, and you will, on physical exam, may have demonstrated some joint line tenderness on that side, which is probably one of the more sensitive signs of meniscal pathology, although it can be due to other things. And you would then proceed to some kind of special test. There's one called a Thessaly test, which is meant to be quite sensitive. I don't have much experience with it. There's an Apley's grind test, which is probably on par really with a McMurray's in terms of special test and its role. And the one I think it's in common use is the McMurray's. So it's not overly sensitive. It's reasonably sensitive, but it's what is good about it is it's quite specific as a test. And the concept is you essentially are going to firstly hyperflex that leg, which is going to squeeze the shock absorbers, and you're then going to specifically, and at that point you may actually find the patient recreates their symptoms. You're then going to specifically compress, say, the medial meniscus to start with, and the first thing you're going to do there is you're going to actually externally rotate the leg, so by moving it, and so that's going to specifically compress the medial meniscus, and that might. So if you get that recreates the pain, particularly when you're doing that external rotation, you're getting a bit suspicious that it's going to be meniscus. And then what you're going to do, having hyperflex the knee, and put in that external rotation, is you're then going to extend that leg. You can add a bit of further compression whilst you're doing that by twisting the leg in, so bowing the leg, which is just going to add a bit more. And what you're going to do is, as you extend the leg, you're suddenly going to get a clunk, which is going to either be felt or heard in association with pain. And when the McMurray's test was written up, a positive test was really defined as the finding of that painful clunk. And then what you're going to do is then you're going to, and you actually might notice you put your hand over the joint so you can feel that clunk as you're doing it. So if I'm testing the medial collateral in particular, I've got one hand over the joint line on that side. And then I'm going to go and change to the lateral meniscus, which is where I again hyperflex the leg. And then instead of internally rotating, I'm going to internally rotate the leg, and then again do that extension, seeing if I get that painful clunk. So that's how the test works. And you can also add a bit of the opposite, putting the legs into valgus to compress it further as you're extending it. So let's see that in action. So first thing I'm going to do is I'm going to just find where that joint line.
Just going to bend this forward as far as it will go.
So I'm going to hyperflex the leg. I've got my hand over my top fingers there that you can see over the joint line. Now I'm probably going to test the medial meniscus first, so you can't see that, but you can imagine my fingers on the other side on the medial joint line as well. And because I'm going to test the medial meniscus, I'm going to put the foot into eversion. So just take note of the finger positioning there. One hand is over the joint line, and the other one is under the foot, which is going to control the external rotation, which is what I'm going to do to compress that medial meniscus. And I'm probably going to do a bit of bow the leg a bit as I now extend to bring it out further. Let's see that in action. So here we go, from hyperflex position, externally rotated, and then compressing and bowing the leg a bit. And I was just waiting to see if I could feel any painful clunk or click or feel it. And I can't. I'm now going to the other side. So Again, hyperflex the leg, feel over the joint line. Now internally rotate the leg. I might ask if you got pain, where has it felt? And doing exactly the same thing, except this time I'm putting force to put the leg into a valgus position. But the most important thing is I'm maintaining that internal rotation, which is sort of the key part. Now, if you can't physically hyperflex the leg, there's no point trying to do the rest of the test, because you can only do the test if you can actually hyperflex the leg, and a lot of people acutely can't, and that's one of the limitations of this test. But if you do find they get pain as you're trying to flex the leg, well, ask them, where do you feel it? And if it's over that meniscus that you're concerned about, then that supports that. And if you find by say everting the foot, it recreates specifically their medial meniscus pain even more, well, that adds even more argument that they probably have a meniscal pathology, even though you haven't strictly fulfilled the full criteria of the test. So that's the McMurray is very specific, which is where it's quite valuable. Alright, we now just finish the exam by going in the prone position, and there's a few things do here. You can re-inspect. So remember, it's inspection, palpation, and then move. Now we've already done the movements, so really here it's more just about inspection and palpation, and we've so inspection. The inspection is going to be very similar to what we did in the standing position. Now just looking at the skin, the muscles, the bulk, and then specifically for a cyst, a Baker's cyst, and just making sure the alignment's okay. So this will now then focus on the palpation. In terms of palpation, this is the best time to feel for that. And what you might notice is that there's the hamstring. So you've got your biceps femoris out here laterally, and over immediately you've got your semitendinosus and membranosus, and they all link on. These ones come out into here, and these ones come out there somewhere. So you're getting them coming out through here onto the tibia, and then you've got your calf muscles, your gastrocnemius heads coming through here, and then in between, then you've got a trapezial artery you can palpate, and you've got between the heads of the membranosus and tendinosus, you might often get that might be where a Baker's cyst might appear, which is one of the causes of pain. And then if you want, you can feel the calf for tenderness. So they're the sort of things you're going to feel for here. This is pretty important. So, for example, if I had someone who I suspect had a biceps femoris tendinitis, so that's the hamstring here. Well, I might know, because they get pain in this area. When I did my resisted motor testing, I noticed when they flex their leg, it's tender and actually recreates pain here, and that pain recreates the usual pain. When I palpated it, recreates the usual pain that they come in with. So logically, the thing I want to do is palpate that and see if that recreates the usual pain. Because if it does, then I've really fulfilled the criteria that that's their diagnosis. So that's how this works. But to know where that muscle is, you need to sometimes get it to contract so you can actually see it. So let's watch that in action.
That's it. Just push against me.
Yes, and here I'm trying to now bring out those hamstrings where they're inserting. And having identified them, I might now specifically feel each of those tendons. Having identified where they are, I will also know where the Baker's cyst is going to be if I'm going to feel it, and also where the trapezial artery. So here I am palpating.
Okay. And any pain in there at all?
Now that's the fibula head, which is the last thing I check there. You can also feel that from the front.
That's fine. What's that?
And that's it. And so that concludes this PowerPoint on the knee, and I hope you found that useful.